Hello, we're glad you've joined us for this live webinar, Influenza 2018 to 2019. Are you ready? I'm Judy O'Rourke of Labroots, and I'll be moderating this session. Today's educational web seminar is presented by Labroots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. DiaSorin Molecular continually monitors the major flu databases and tests emerging flu strains on an ongoing basis. 92 strains have been validated, with more strains tested regularly to provide confidence in your results. This presentation is brought to you by DiaSorin Molecular. DiaSorin Molecular manufactures and distributes innovative molecular diagnostic products for hospital and reference labs. The company's products help laboratories consolidate testing, streamline processes, and increase efficiency. Its Simplexa molecular diagnostic kits are designed for use on the company's versatile Liaison MDX platform. The Simplexa Flu AB and RSV Direct Kit provides simple direct detection and differentiation of influenza A virus, influenza B virus, and RSV with greater than 97% sensitivity. To learn more, visit molecular.diasorin.com. Let's get started. You can pose questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them into the drop-down box located on the far left of your screen labeled Ask a Question and click on the Send button. Questions will be answered after the presentation. To enlarge the slide window, click on the arrows at the top right-hand corner of the presentation window. If you experience any technical problems seeing or hearing the presentation, just click on the Support tab found at the top right of the presentation window, or report your problem by typing it into the Answer Question box located on the far left of your screen. This is an educational webinar and thus offers free continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process of obtaining your credits. I now present today's speaker, J.M. Lieberman, MD, Medical Director for Pediatrics at PRA Health Sciences. Dr. Lieberman is a specialist in pediatric infectious diseases, having completed his residency training in pediatrics at Children's Hospital of Los Angeles and fellowship training in pediatric infectious diseases at Children's Hospital of Los Angeles and at Harbor-UCLA Medical Center. Dr. Lieberman joined PRA Health Sciences as a medical director in 2017 after 4 years as a regional medical director for Merck Vaccines. Prior to that, he was medical director of infectious diseases at Quest Diagnostics and laboratory director for Focus Diagnostics, an infectious diseases reference lab owned by Quest. Before joining Quest in 2007, Dr. Lieberman was professor of clinical pediatrics at the University of California, Irvine, and chief of infectious diseases at Miller Children's Hospital in Long Beach. His clinical research activities have included the evaluation of vaccines, other biologics, and antimicrobials in children. He has published articles on a wide variety of infectious disease topics and was frequently an invited lecturer at national and international meetings. His complete bio is found on the Labroots website. Dr. Lieberman will now begin his presentation.
Judy, thank you very much. Greetings, everybody. It is my pleasure to be talking to you today about influenza, making sure that you're ready, both from a professional and a personal standpoint, for the upcoming influenza season. This is a picture of my family. A number of you, many of you, I presume have heard me speak in the past. I like to keep you updated with what's going on in my family. I hope you realize this is a picture from Halloween. This is not our normal attire. My family, we don't believe in these, group family pictures where we all dress the same. We kind of rock our individuality. My wife and my son are ninjas. Two of my daughters are from Alice in Wonderland. I've got a daughter who's a dinosaur, and I'm a Starfleet captain. One of the things that I like to do for Halloween is I usually dress up as a king or a captain, some kind of person in charge, because it means for at least one day out of the year, I can pretend to be in charge of this crew. We had a lot of fun on Halloween. What Halloween means, of course, is it's It's fall. It means that the holidays are coming up, and it also means that influenza season is right around the corner. So let's talk about influenza, and I want to start with a couple of clinical cases, because there are a number of misperceptions about influenza that affect how people think about it, what they do to try to prevent it, and how they treat it. Unfortunately, one perception is that the flu may not be so bad. And indeed, in many people, it's a frustrating, annoying illness, but it also causes a lot of morbidity and mortality, as we'll talk about in just a little bit. And so I want to present two cases from my time working at a children's hospital. The first case, this was a previously healthy 8-month-old male, admitted with a 24-hour history of irritability, didn't actually have any history of fever, cough, or rhinorrhea. On his physical examination, he was irritable and diffusely hypertonic. His eyes were open, but he would not fix and follow. The patient's mother said that she'd had the flu about 5 days earlier. A lumbar puncture was performed, no obvious pleocytosis, but a markedly elevated CSF protein. A CT scan of the brain showed a 1.5 centimeter hypodense area in the deep white matter. He was minimally responsive for the first week, but he did improve gradually. But even at discharge, he was not normal. He was not able to feed, and he was discharged home with a G-tube. We did an extensive evaluation for possible etiologies of his encephalitis, and the only positive result we got was that the CSF grew influenza B. This was before widespread PCR use, not that we would have done PCR for influenza from the CSF. This is a very unusual case, but this patient had influenza encephalitis, and I don't have long-term follow-up, but even a couple of months later, he'd still not returned to his neurologic baseline. Next case, a little more typical bad outcome from influenza. This was a previously healthy 21-month-old male admitted initially to an outside hospital with 4 days of fever, decreased activity, progressive cough, and respiratory distress. He'd been prescribed amoxicillin for an acute otitis media the day before he was admitted, and the chest x-ray showed an extensive right-sided pneumonia. Upon admission, his laboratories were significant for a low white count, with 20% segs and 26% bands. He was started on an intravenous cefuroxime, but he rapidly deteriorated. When he arrived in our pediatric intensive care unit, he was in shock and respiratory failure. His tracheal aspirate was positive for influenza. His blood grew MRSA, and he had MRSA pneumonia and MRSA sepsis. This is a picture of him that I took upon admission. He was critically ill, requiring ventilator support, support for his blood pressure, and the most striking things on physical examination you can see were his extremities. He survived this infection, but he required a left below-the-knee amputation, and he required half of his right foot to be amputated as well. And so this is a consequence of his MRSA sepsis. Why did he have MRSA sepsis? Because he had influenza. And one of the complications of influenza is secondary bacterial infections. And had he not gotten influenza, he would not have gotten MRSA sepsis. When I gently kind of probed with the parent about whether or not he'd been vaccinated against influenza, she commented that they'd actually been to their doctor several weeks earlier, the pediatrician, and she'd asked about a flu shot. But the pediatrician said no, he didn't need one because he was healthy. This is the consequence. So again, influenza can be a very serious disease with significant complications, even in otherwise healthy individuals. So the virus is an RNA virus of the orthomyxovirus family, and I'd emphasize here that we're talking about influenza. And one of the other problems with influenza is that it often gets abbreviated as flu. And the flu is a nonspecific term that people use for a variety of illnesses that may or may not be caused by influenza. As much as possible, I'm going to say influenza to remind you that it's a specific virus, although even I lapse sometimes and call it flu. There are three types of influenza virus, A, B, and C. We're going to predominantly talk about A and B. Type C influenza is a much less common cause of illness in humans, primarily affecting young children, a very rare cause of illness in adults. Influenza A viruses, in contrast to B and C, infect not only humans, but also animals, such as birds, horses, and pigs. And this is going to be very important, as we'll talk about in just a moment. And another key aspect of the virus is that the influenza viruses undergo frequent genetic mutations. A little anatomy of the influenza virus. This is a number of the constituents of the virus. I focus on just two here, two outer proteins of the virus, hemagglutinin and neuraminidase, often abbreviated, will be abbreviated H and N. Hemagglutinin is a glycoprotein on the surface of influenza viruses that's responsible for binding the virus to cells of the respiratory tract. Neuraminidase is another surface protein. It's an enzyme that enables the virus to be released from the host cell and is required for viral replication. Some influenza nomenclature, viruses get named. They get named as to their type, A, B, or C. The geographic source where the specific virus was first isolated, in this case California, an isolate number. This was the fourth such virus that was identified, the year of isolation, in this case 2009. And then influenza A viruses get further subtyped as to the specific hemagglutinin neuraminidase. So this is an H1N1 virus, and as you may have already recognized, the virus that's being named here is the pandemic 2009 virus that was first identified in children in California. So the other thing I said was that these viruses undergo frequent genetic mutation, and there are two types of mutations. The first type is antigenic drift, and these are minor mutations in the hemagglutinin and neuraminidase within one subtype. So you have an influenza A, it's an H1N1, it's a USSR 1977, it drifts and it becomes an H1N1 Brazil 1978. Antigenic drift occurs in types A, B, and C influenza. We still have partial immunity from exposure to previous similar viruses, but it's this antigenic drift that's responsible for our annual epidemics of influenza. In cartoon form, this is what happens with antigenic drift. You can see here there's a minor mutation in the hemagglutinin, a minor change. It's still the same HN subtype, but it's drifted. And as a result of this drift, as I've said, you have these annual influenza epidemics. These epidemics affect specific geographical areas. They're seasonal. And so these drifts are one of the major causes of seasonal flu. The attack rates due to epidemics are lower than in pandemics, which I've not yet defined. And the major effects, what we see every year, increased rates of hospitalization, increased absenteeism from work and school, and a rise in excess mortality. People die from flu. If you look at the burden of influenza in the United States, the CDC looked at the years 2010 through 2016 shown on the left, and there's a range. The severity of flu seasons varies year to year based on the types that are circulating, specific types circulating, whether we've seen them before, the match between the strains in the vaccine and the types that are circulating, and the difference between the different types themselves in terms of the severity of the disease they cause. So between 2010 and 2016, CDC estimated about 12,000 to 56,000 deaths per year, 140,000 to over 700,000 hospitalizations a year, and tens of millions of cases. This past flu season, 2017-2018, was characterized as a high severity season. High levels of influenza-like illness visits, high hospitalization rates, and an estimated 80,000 deaths. So think about that for a second. If I said that there was an infectious disease that caused between 12,000 and 80,000 deaths a year among Americans. You'd probably say, oh, I wish we had a vaccine to prevent that. Well, indeed, there is such a disease and there is such a vaccine, and yet many people who would benefit from vaccination don't get vaccinated. The 2018 season was a predominant influenza A H3N2 season. And historically, H3N2 seasons tend to be more severe than H1N1 seasons. Why was it so severe? Again, H3N2 was a predominant strain. In addition, the vaccine was not as effective as we would have liked it to be. It's never going to be 100% protective, not with the current formulations of vaccines. But the effectiveness against H3N2, that was the predominant vaccine type circulating, was only about 25%. The overall effectiveness against the circulating types was about 40%. Now, whether you see this as a half glass full or half glass empty depends on your views of life. Not ideal. You can still get influenza after getting the flu shot, but it offers you the best chance of being protected. And if you can reduce your risk by 25%, 40%, 50%, you should take advantage of that. Bottom line, a lot of disease caused by influenza every year in the United States. And talking about deaths, if you look historically, in general, more than 90% of deaths due to influenza each year occur in people 65 years of age and older. And that's why historically there's been so much emphasis, so much focus on making sure that adults, and particularly the elderly, get vaccinated. But it's not only adults who get sick and adults who die. Children actually are more likely to get influenza, primarily because of their intimate contact with other children and their lack of pre-existing immunity, particularly if they've not been vaccinated, and children do die. And so pediatric deaths due to influenza are reportable. And if you look back over the past decade or so or longer, it's about 100 children die every year from influenza. In line with last year being a more severe season, the number of deaths reported was over 180. Many of these children do have underlying conditions, but many of them also are otherwise healthy. And so to protect our children from influenza, they should be vaccinated. The other side benefit, which I'll mention again later, is that children are the vectors in the community. And so vaccinating them also protects all the people, the adults, the grandparents that they come in contact with. So that's antigenic drift, responsible for our annual epidemics of influenza. The other type of mutation is antigenic shift. And this is a major change from an old to a new viral subtype. For example, from H2N2 to H3N2 as a result of reassortment between two subtypes. Antigenic shift occurs only among type A influenza viruses. It's a new virus with a novel antigenic profile. The population does not have antibodies, and this is what results in pandemics, antigenic shift. So in cartoon form, you've got, as I've said, influenza viruses, influenza A viruses that affect not only humans but animals, such as birds, including ducks. So you've got an influenza A virus that infects humans, an influenza A virus that infects ducks, and then the virus can reassort, oftentimes when it infects a common host such as a pig. And in the pig, the viruses reassort. This doesn't occur commonly, but when it does occur, you wind up with a novel virus. In this case, a virus that has the hemagglutinin from the duck or avian type of influenza and the neuraminidase from the human type. And so now you've got a novel virus. And this is what can lead to pandemics. So pandemics follow antigenic shift, historically occur in cycles every 10 to 40 years. It affects the entire globe. The onset could be any season, not just wintertime. High attack rates in all age groups, and morbidity and mortality are markedly increased. So if you look over the past 100 years now, before the most recent pandemic, here were the three other pandemics. The so-called Spanish flu was 100 years ago. We're celebrating the 100th anniversary of the Spanish flu. This was the worst pandemic of the 20th century. Estimated approximately 50 million people around the world died from Spanish flu. About 40 years later, the Asian flu, an H2N2 flu, caused severe disease. 10 years later, the Hong Kong flu, H3N2, caused moderate disease. And then we're waiting, and then in 2009, H1N1. And we'll return to that topic in just a moment. What I'd like to emphasize here, though, is that when a pandemic virus hits, it looks different than the typical, and its impact looks different than the typical seasonal flu. So I've already mentioned that with the annual epidemics, about 90% or more of the deaths occur in people 65 years of age and older. When you've got a pandemic virus, a new virus, a novel virus, that changes. So if you look back at the Spanish flu, 1918-1990, an H1N1 virus, in that first year, 99% of the deaths occurred in people younger than 65 years of age. You look 30 years, 25 years in the future, still a third of the deaths occurred in people under 65, and then the current, or the recent H1N1, you're back to baseline. The Asian flu in 57-58, more than a third of deaths in that first year occurred in people under 65. The Hong Kong flu, almost half of deaths occurred in people 65. So it's a very different pattern than you see with seasonal flu. Let me switch gears a little bit and talk about avian influenza. And as I said, so for example, the 1918-1919 Spanish flu was an avian flu. And so part of pandemic preparedness is to see what's going on in the world, not only among humans, but among animals, including birds, because we know that's oftentimes that the strains that affect us, that become the pandemic strains, start in other species. So avian influenza is an infectious disease of birds. It's caused by influenza A virus strains. There are 15 known subtypes that affect birds. The avian flu in birds causes a wide spectrum of disease, ranging from mild illness to a highly contagious and rapidly fatal disease. The highly pathogenic strains tend to be of two types, H5 and H7. Usually, avian influenza strains do not infect species other than birds and pigs, but that's not always true. Hong Kong in 1997 had a major outbreak of avian flu. It was an H5N1 virus, and type A H5N1 had been first discovered in 1961 in terns, and terns are a type of fowl, that's not interns. And then in 1997, thousands of chickens in Hong Kong died due to H5N1. In May 1997, an H5N1 virus was isolated from a 3-year-old boy. And between May and December 28, 1997, there were 18 confirmed cases, 1 suspected case, broad age range, and 5 deaths due to H5N1 in people. And the concern at the time, appropriately so, was now you had a novel virus that could infect humans and make them very sick. And the concern was this could be the next pandemic. You'll notice in the last bullet there it says December 28, 1997. What happened on December 28th? Why did this outbreak so abruptly kind of halt? Well, the reason is that on December 28th, they started killing all the chickens. And the reason H5N1 to this day has not become a pandemic virus is we learned that while the virus could infect humans and make them very sick, the transmission was almost exclusively from chickens to people. So as humans who had close contact with sick chickens, the virus is not transmitted easily from person to person, and therefore it has not become a pandemic strain. Nonetheless, over the subsequent 20 years, H5N1 infected birds were subsequently reported not only from Hong Kong, but through various areas in Asia, Africa, and Europe. Birds fly, and there were a number of human cases, and again, you can see the high deaths due to H5N1. But again, 20 years later, it has not become a pandemic strain. More recently, in 2013, human infections with another novel influenza A virus, an H7N9, were first reported in China. Since 2013, more than 1,500 cases in humans and 600 deaths. Again, a nasty virus. You can see the epidemiologic curve on the right. More cases this past year than in the previous years. But again, no evidence that the virus is transmitted easily from person to person. And so this is something that needs to be monitored. The viruses can mutate and become more easily transmissible, in which case they could become a pandemic virus, but that has not occurred to date. And so if you were to have tried to predict 10 years ago what's going to be the next pandemic strain, and you were a betting person, you'd have said it's probably going to be an avian influenza strain and will probably originate in Southeast Asia. Of course, that turned out not to be the case, which again just speaks to the unpredictability of influenza. So let's talk briefly about the 2009 H1N1 pandemic outbreak of flu. So this was a swine influenza A, and we first became aware of it in April 2009 when it was recovered from 2 children in Southern California. And these children did not have contact with pigs. They didn't have contact with each other. And the virus contained a unique combination of gene segments that had previously not been reported among swine or human influenza viruses in the United States or elsewhere. And so with the identification of these novel viruses that could infect people, everybody went on high alert. What's happening? And what we recognized that was happening was that starting in March and early April 2009, there were outbreaks of an influenza-like illness in several areas of the country. On April 23rd, this novel H1N1 virus, the swine flu virus, was confirmed. And control measures were instituted, the next day. They closed schools, they discouraged large public gatherings, while trying to figure out what's going on. When we looked at the United States, it wasn't limited just to the 2 kids in California. And by the time we recognized it, it had already spread significantly even in the United States. As we learned more and more in the weeks ahead, the swine flu went through this cycle about what it was doing and its perception. And in the initial weeks, there was a lot of hysteria. And people were panicky about what was going to happen. What turned out, of course, was that, fortunately for us, H1N1 disease in humans was generally mild to moderate. And to some, the conclusion became it was just a lot of hype. Well, first of all, the problem with that is, at the start, you don't know how it's going to progress. And so you've got to take it extremely seriously and get ready. And the other point is, it wasn't just a benign illness. So if you look at the pandemic strain, you can see 12,000 deaths or so, 275,000 hospitalizations, not worse than a normal flu year, and lots of cases. But the striking thing here is look at the deaths again, right? Because it's usually 90%, or so in people over 65. They're skewed more left. The hospitalizations are skewed far to the left. And so this had a major impact in young children. And it was predominantly pediatric hospitals, urgent care centers, pediatric, ERs that saw the brunt of this illness and got swamped from it because it was the kids that were getting sick. In addition, the deaths in children were about 4 to 5 times what we've seen in a normal year. Just again to highlight the difference, this was just for the first couple months of the outbreak. In blue are hospitalizations by age in a normal seasonal year. With the pandemic in black there, you can see again the hospitalizations are skewed to younger individuals. So it was bad, but not nearly as bad as it could have been. And just because the virus didn't cause serious disease. We learned a lot from the pandemic in 2009. We learned a lot about how we're not as well prepared as we'd like to be. And we learned a lot about diagnosis of influenza. And the outbreak really shone a light on influenza diagnostic capabilities and some of the limitations. So let's talk about diagnosis of influenza. So first of all, why diagnose influenza? Generally a self-limited illness. Well, there are a variety of reasons. One, you can provide specific antiviral therapy for indicated patients. And as we'll talk about a little later, there's benefit to treating influenza. In addition, you avoid things that you don't need. You avoid unnecessary antibiotics, which obviously can have a negative impact for the patient. You avoid unnecessary evaluations for other causes of illness. As I'll show you in just a moment, making a specific diagnosis means fewer unnecessary tests, fewer unnecessary therapies. In hospitalized patients, we hate it when a hospitalized patient who's there for something else develops a new fever. What's going on? Is this some major complication, a post-operative infection? Do we need to change their antibiotics for something we're treating? Or does it happen to be not good, but does it happen to only be a hospital-acquired infection, a viral infection? And so we don't need to really escalate therapy or escalate diagnosis. It also helps isolate hospitalized patients appropriately and understand what's going on in the community. So just a couple of quick slides, the impact of making a diagnosis. Just two short studies that look at rapid testing for influenza in adults and children. First, in adults, this was a retrospective study of hospitalized patients with influenza whose antigen test was positive compared to those who had negative tests. The rapid test was not done, but they had influenza. Those who had the rapid test that was positive, they had less antibiotic use, greater antiviral use. That's good for the patient. However, many antigen-positive patients still received antibiotics despite the absence of an indication. And one of the things we've got to do is educate clinicians, and they've got to feel comfortable that the diagnosis is correct, and they don't have to look for other things to explain it, which doesn't mean that some patients with influenza don't need antibiotics, of course. In children, this was a prospective study of febrile children seen in an ED in Alabama. All the patients had a rapid test obtained while they were in the ED, but in half the patients, the test wasn't done until 24 hours later. In patients who were positive for influenza, those who had the rapid test done in the ED, fewer tests, fewer CBCs, fewer blood cultures, fewer chest x-rays, fewer urine cultures. They also spent less time in the ED and had fewer antibiotics prescribed. Those are tremendous outcomes. That's a big impact. And I'd also emphasize here they're using rapid tests. How much better would it be with a more sensitive test so you have more confidence in the diagnosis and you make the diagnosis more accurately, more frequently. So who should be tested? These are from guidelines published by the Infectious Society of America in 2009. So during influenza season, and I'd emphasize that, it should be during the season, testing should occur in the following persons with febrile respiratory symptoms, if the result will influence clinical management. So certainly outpatient, immunocompetent persons who are at high risk of complications. And we'll talk about those. These are the people for whom vaccine is really recommended because they're at risk of diseases. So people with asthma, heart disease, diabetes, etc. In addition, outpatient immunocompromised persons, and then hospitalized people. And I think that every hospitalized patient who's coming in with a febrile respiratory illness should be evaluated for influenza, if not also for other respiratory viruses. Who else should be tested? During influenza season, testing should occur in the following persons if the result will influence clinical management. So people at the extremes of age, elderly persons, and infants presenting with suspected sepsis or fever of unknown origin, in those age groups, they are less likely to have classic influenza symptoms, including respiratory symptoms. Children with fever and respiratory symptoms presenting for evaluation, and people who develop fever and respiratory symptoms after admission, because unfortunately, hospital-acquired viral respiratory infections are still too common. The CDC has guidelines for who to consider for influenza testing. I'm not going to go through the whole thing, but I just want to make a couple of points. First of all, do they have signs and symptoms suggestive of influenza? Yes. They're admitted to the hospital? Yes. Test them. Start empiric antiviral therapy while you're waiting for testing results. I'll reinforce that later. And the real thing I want to emphasize here, on the bottom left-hand corner, molecular assays should be used for influenza testing of hospitalized patients. You want the most sensitive test available, and that's going to be a molecular test. And then we'll talk about interpretation of testing results. As all of you know, we've got a wide variety of influenza virus testing methodologies, and these have evolved over time. Classically, viral tissue cell culture, that was the gold standard. It yields live virus. The major drawback, of course, is the time. You're not getting results oftentimes. The rapid culture techniques obviously improve that, but you're not getting it when you want it, when you most want it, where it's going to have the biggest impact on clinical management. The immunofluorescence staining, DFA or IFA, more rapid results, but as we'll talk about, not quite as sensitive. We're going to talk about the rapid influenza diagnostic tests, which has become increasingly common, increasingly used. They're anti-detection. You can get results, in 15, 20 minutes, but they've got drawbacks. As those CDC guidelines suggest, we're really in a molecular age now. And the variety of diagnostic testing methodologies and platforms, but these have become really the gold standard. And where you want to be is going to have the biggest impact on clinical management of patients. I said that the 2009 H1N1 pandemic really shone a light on the diagnostics. And this is from a study published in late 2009, a large study where they looked at over 6,000 patient samples submitted for H1N1 testing over a 5-week period, submitted for influenza testing over a 5-week period. And they looked at a variety of different testing methodologies, including rapid antigen tests, DFAs, viral cultures, and PCR. And the big take-home message was the sensitivities. So the sensitivities of the two rapid tests were 18% and 48% respectively. In other words, one of the rapid tests missed more than 80% of the positives. The other missed more than half. DFA missed half the positive influenzas. Viral culture got 90% of them. But as I said, molecular testing, PCR, was the gold standard. And I think that the 2009 outbreak, the H1N1 outbreak, really drove, molecular respiratory testing in general, and appropriately so. There have been a number of other looks at the rapid test, a number of meta-analyses. This is the most recent one published. This meta-analysis of 162 studies compared these rapid tests, the newer digital immunoassays that have an instrument-based digital scan of the test strip. And so it takes away some of the subjectivity of the classic rapid tests and, a rapid nucleic acid amplification test, a molecular test in children and adults with suspected influenza. The bottom line showed in the second bullet, the pooled sensitivity for the rapid tests was 54%. You're missing half the cases. For the DIAs, better, 80%. For the molecular tests, 92%. Again, highlighting the deficiencies of the rapid tests. In this study, the sensitivities for detecting influenza B were similar to influenza A. Other studies have shown differences. We also know there tend to be differences between children and adults. A test in a child, a rapid test in a child, is more likely to be positive than a rapid test in adults. The reason for that is that children tend to shed higher titers of virus. There's more virus, and so the tests are better in children than in adults in general. CDC guidance on the rapid tests, highlighting the limitations of sensitivity. I emphasize the second bullet point here, that the positive and negative predictive values vary considerably, and it's dependent on the prevalence of influenza in the population being tested. What does that mean? If you do a rapid test in a patient in August, when you don't have influenza virus circulating in the community, any positive you get is almost surely going to be a false positive. Whereas if you do the test when the virus is very common, you can be much more confident that a rapid test that's positive truly represents an infection. And so at the beginning, at the end of the season, their function utility is lower. And again, at the beginning and the end of the season, a molecular assay is going to give you better, more accurate results and tell you what's going on in the community. The bottom line is that a negative rapid test does not exclude the possibility of influenza virus infection. And again, this is something we learned in 2009 very clearly. I remember very vividly a lab director at one of our local hospitals was sending us specimens that they had tested for influenza at the beginning of the H1N1 outbreak. And what they were doing is we had developed a test that could specifically identify the 2009 H1N1 pandemic strain. So they'd have a positive rapid test for influenza A, they'd send it to us, and we would confirm that it was the 2009 H1N1 or that it wasn't. One day, by mistake, they sent us their negatives. And I forget the numbers, but they sent us about 7 or 8 negative rapid tests for influenza. And on 3 or 4 of them, we identified it as 2009 H1N1 positive. And the lab director called me and said, I think you have a problem with your test. And I had to correctly, kindly explain to her, no, it's not a problem with our test, it's a problem with your test. And, you know, we had to all learn that the rapid test had deficiencies. You're probably aware that as a result of everything we've learned over the past decade, in 2017, the FDA reclassified the rapid tests from Class 1 to Class 2 devices with new minimum performance standards and a requirement for annual reactivity testing. And the goal is to assure the reliability and accuracy of the rapid tests, reduce the likelihood of false negative results, and thereby aid clinicians who are trying to use the results to help patients. As a consequence, many previously available rapid tests can no longer be purchased in the United States. And here's what the reclassification does. It identifies the minimum acceptable performance criteria, requires the use of a currently appropriate and FDA-accepted comparator method, which is going to be a molecular method, for establishing the performance of new antigen-based rapid tests. And I think also very interestingly and importantly, require annual analytic reactivity testing of contemporary influenza virus strains, and require analytic reactivity testing of newly emerging strains under certain conditions. And so the CDC now has a panel of viruses against which the rapid tests will be tested with each year to make sure that they're able to detect the viruses that are circulating. In the instance of a potentially emergent virus, they'll do the same thing to make sure that the rapid tests that are already available can actually detect new viruses that may be circulating or the commonly circulating strains. So here's just one example of possible problems. There was an H3N2 variant virus. It's a swine virus that several years ago was affecting pigs in the Midwest United States and infected some humans as well. And they were people who had contact with the pigs, either because they worked on a farm, at petting zoos, etc. And so that led to an analysis of some of these rapid tests. When they looked at the rapid test, they could detect the seasonal H3N2, the human strains, and all but one detected the pandemic H1, but only 4 of 7 were able to detect all these variant strain viruses. And the hypothesis was that the reduced sensitivity of the rapid test to the variant virus was due to differences in the nucleoprotein in the swine influenza. The point being that not only do we want to treat our patients, but we've got to be alert to the fact that as new viruses emerge, our tests may not be as good, and that as the virus drifts, our tests might not be as good. And so this is extremely important. I'd also emphasize this is a potential problem not only with rapid tests, but some of the molecular assays. They have different targets. And so as new viruses emerge, as there are mutations, we've got to be sure that our molecular tests are, one, able to detect the novel virus, and if they are able to detect it, can they determine what type it is accurately as well? And so because the influenza viruses mutate, we've got to be consistently reevaluating the tests that we're using to make sure that they are staying up to date with the virus as it evolves. So what we've seen over the past 30 years is a real evolution in viral diagnostic testing, not only for influenza but other respiratory viruses. We've gone from viral culture to fluorescent antibody testing to rapid antigen detection, and more recently to highly sensitive molecular tests, as well as a trend of testing at or near the point of care. And this trend is only going to accelerate until I believe molecular testing at or near the point of care becomes routine. We want the best test available to give us a timely result in time so it impacts our management of patients. And so that's where many of us are, and the rest of us will be going because that's where we want to be. Switching gears now, just spend a little bit of time on treatment. The mainstay therapies are neuraminidase inhibitors. There are 3 available in the United States. The one you know most commonly is oseltamivir, available now as a generic version or the trade name Tamiflu. And this is a tablet you take for 5 days. Zanamivir is an inhaled neuraminidase inhibitor. So you can't use it in people who've got respiratory illnesses like asthma. And peramivir is a more recent antiviral given intravenously. The exciting news is a couple of weeks ago, baloxavir was licensed in the United States. And it's the first new antiviral influenza treatment with a novel mechanism of action to be approved in almost 20 years. It's been approved to treat uncomplicated influenza in patients 12 years of age and older who've had symptoms for no more than 2 days. And I'd emphasize here that this no more than 2 days is really true for all the antiviral, anti-influenza therapies. You want to start them as early as possible. The greatest clinical impact is seen when you start them early in the disease course. For most patients, it's a 4, 5, 6 day illness. You starting it at day 5 in general is not going to have a large impact or any impact that you'll be able to measure at all. That's not to say that you don't use it in high-risk patients or very sick patients more than 2 days out. But if you're going to have an impact in the patient you're seeing in the ED, the urgent care center, just hospitalized, you want to start as early as possible, which again speaks to the need to make a diagnosis early. This is from the Efficacy Trial. It's a single-dose oral medication, so that's kind of cool. It's 1 dose. And so now you can see where you can really impact a patient's clinical course if you can make a diagnosis and treat them and complete the treatment in the same visit. Single-dose oral medications significantly reduce the duration of symptoms by more than 1 day, and the efficacy was comparable to oseltamivir. You can see on the right, the impact is not tremendous, but you're making people better, reducing fever, reducing symptoms by more than a day on average. And for the patient who's ill, that's really, that's significant. They get back to work a day earlier. They're able to take care of their family a day earlier. They get back to school a day earlier. They're shedding less virus, making them less contagious to others. So, this is not meant to minimize the potential impact of effective therapy given a diagnosis of influenza. And again, having another drug in our armamentarium is obviously a very good thing. So the summary, early antiviral therapy in people with influenza can lessen illness severity, shorten the time of illness, and reduce flu-related complications. And again, to re-emphasize, clinicians should not delay decisions about starting antiviral therapy while waiting for laboratory confirmation of influenza. If there's a strong reason to treat, don't wait for the test results. But again, the better answer is get your test results quickly so you can treat those who most need it. Influenza 2018-2019, just around the corner. The CDC every week publishes updates on influenza activity. The map in the week ending October 27th, there's not a lot going on. A couple states have some local activity. There's some sporadic activity. But in the weeks ahead, we expect this map to start changing as influenza season hits. One of the ways the CDC looks for influenza is looking at ILI, influenza-like illness in outpatients. And not all ILI is influenza, but measuring it tells you when influenza starts. The gray line on the left, that's the 2009 pandemic. The season started when kids went back to school. So it was a really September, October illness. By November, December, it was pretty much gone. The teal that peaks in the middle, that's last season, 2017, 2018. You can see higher peak, kind of broader peak as well. It was a severe season. The red diamonds that you see in the bottom in the left, that's this year, 2018, 2019. And you can see ILI slowly starting to tick up. That dashed line, when it hits 2.2, we're saying that's influenza season. If you were betting, you'd say we're probably 3-4 weeks away from influenza season. But we'll see how it goes, and we'll see what the year is like. Finally, prevention. And the primary means of prevention is flu vaccine. The recommendations for the use of influenza vaccine this year: routine annual influenza vaccination is recommended for all people 6 months of age and older who don't have a contraindication with any licensed age-appropriate flu vaccine. And there's no preference expressed for any one vaccine over another. Vaccination should be offered by the end of October. All the people in costume that you saw in that first slide, they've all been vaccinated against flu. But it's not too late. If you've not gotten your flu vaccine, if your loved ones have not gotten one, it's not too late. And vaccination efforts should continue throughout the season because the duration of the flu season varies. Activity does not necessarily occur only in December. January can last until February or March. So bottom line, it's not too late. Routine vaccination is recommended, but there are certain individuals for whom there's a high risk of medical complications, and they should get an increased focus for flu vaccines. All children 6 months to 6 years of age. All people 50 years of age and older. Adults and children with underlying conditions that increase the risk. Chronic lung conditions, including asthma, heart disease, kidney disease, liver disease, diabetes. People who are immunocompromised due to any reason. Women who will be pregnant during flu season. And this is for 2 reasons. One, and this was again emphasized during the 2009 H1N1 pandemic, women who are pregnant are at higher risk of serious influenza disease. They're probably at higher risk for 2 reasons. One, the more pregnant they are, the bigger their belly is, the less lung volume they have. And their immune system is not quite normal when they've got a foreign body that they're going to deliver. And so we saw and we heard of otherwise healthy pregnant women who got severely ill and died from influenza during the 2009 pandemic. So vaccinating pregnant women protects them. It also protects their unborn babies. Through passive immunity, the infant gets some influenza antibodies that can help protect them when they're youngest and most at risk. So pregnant women should be vaccinated. Children and adolescents getting aspirin because of the risk of Reye syndrome, residents of nursing homes and other long-term care facilities, American Indians, Alaska Natives, and people who are extremely obese. Again, it's routinely recommended to all, but the groups we've talked about, we should put a special emphasis on making sure that they get vaccinated. In addition, people who live or care for these people and are therefore at risk for influenza-related complications should be vaccinated. Healthcare personnel. I mean, first, do no harm. If we get sick and we're taking care of patients, we're putting them at risk. And so, unfortunately, historically, healthcare workers, broadly defined, have not done a good job of vaccinating. We've not done a good job of vaccinating ourselves. Increased emphasis, and as you know, many hospitals, other healthcare facilities are really pushing and in many cases requiring that the people taking care of patients get vaccinated. And then finally, the last 2 bullets, household contacts of high-risk individuals should be vaccinated. So household contacts and caregivers of particularly children and the very young children and adults should be vaccinated. Where grandma and grandpa, who are going to be at highest risk of complications, highest risk of death, going to get flu from, they're going to get it from their grandkids. And so vaccinating children protects them, protects themselves, and protects their loved ones. Over the past number of years, we've seen, fortunately, a kind of an explosion of different flu vaccines available in different types, and this can only help us. There are quadrivalent and trivalent vaccines. The quadrivalent vaccines have protect against 2A types and 2B types. The trivalents have 2As and 1B. Again, there is no preference for any specific type as long as it's not contraindicated. The most important thing is that you get vaccinated against influenza. You can see a list of the quadrivalents there. I point out the fourth one is a cell culture grown influenza vaccine. All the others listed here, they're grown in egg cell culture, and so that's a newer way of doing it. There's also a quadrivalent recombinant vaccine, flu block quadrivalent, so not even grown in cell culture. There was also a study this past year that suggested that it might be more effective than the traditional inactivated cell culture grown vaccine, but again, more information is needed before making a recommendation. You see the trivalents here. I just point out the first one is the high dose vaccine. A number of studies have now shown that in people 65 years of age and older, it looks to be more effective than the standard dose vaccine. I make sure my mom gets the high dose vaccine every year. And then the final one is the live attenuated vaccine, the nasal spray vaccine, FluMist, available this year, after not being available the past couple of years. It was not available, recommended the past couple of years because for a couple of years, for some reason, it was not effective against the H1N1 viruses, the pandemic strain that was circulating. That appears to have been resolved now. It's available for those who absolutely do not want shots. It is certainly a very good option. And before it was pulled temporarily, there was evidence that it was better in children than the standard inactivated vaccine flu shot. All of my kids got the flu shot this year because at the time we went, our pediatrician had not received FluMist. So the summary, annual epidemics of influenza result in significant morbidity and mortality. Flu affects not only those at high risk, but even the healthy, and so we should all be protected as best we can. The accurate diagnosis of influenza infection can provide benefits to the individual patient and to the community. And as I've said, molecular diagnostics that give you more rapid results are where many of us are and where the rest of us need to be heading. And then finally, annual immunization is the most effective strategy to prevent influenza. Unless there's a contraindication, you and your loved ones and the people you work with, whether or not you love them, should be vaccinated against influenza. That concludes my presentation. At this time, if you have any questions or comments, I would welcome them.
Thank you, Dr. Lieberman, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them into the drop-down box located on the far left of your presentation window labeled Ask a Question and click on the Send button. Dr. Lieberman will answer as many questions as time permits. First question is, why are birds and pigs the main flu reservoir in which antigenic shifts occur?
So the shift actually occurs in various places, but it's the avian and swine flu viruses that have most commonly been involved in human pandemics. So for the different animals, so it infects not only birds and pigs and humans, but horses, dogs, cats, there are specific H and N subtypes that infect different animal species. And so the types that affect horses, for example, different H types don't have the capacity to infect humans. The specific virus, the specific hemagglutinin, for example, is not able to attach to human cells. But what can happen is that the viruses mutate, and over time they evolve. And the classic shift occurs, as I said, when you have two different viruses that reassort. They exchange genetic material. And so what you need is a two viruses that can infect one species, an intermediate host. And so, as I said, the classic type is that you get an avian flu strain and a human flu strain, each of which can infect a pig. And while in that pig, the virus is reassorted, and you wind up with a novel virus. And so it takes a lot for antigenic shift, which is why it doesn't occur very commonly at all. Most of the time, if it does, it's a dead end. It can't infect other species or even make the original species sick. But every once in a while, you get the right combination occur, and you wind up with a potentially deadly virus. And it's all related to, mutations, and it's a highly mutable virus. And, and then what kind of contact do you have? Do you have contact between these different animals, between pigs and animals, between pigs and birds, between those pigs and humans? And so it takes a lot, and we don't fully understand the dynamics and why that occurs.
Thank you for that. Next one is, in a hospital setting, our clinical caretakers have more and more responsibilities for lab testing, which takes away from their time to care for the patient. How important is it to have a flu result at the point of care?
So as a clinician, my general philosophy was knowledge is power. When you're asking me to see a patient, or I'm going to see a patient, I've got two major responsibilities. One, what's going on? What's the diagnosis? And then second, what do I do about it? But it all starts with what's going on. What do you have? And so any information I have that helps me understand what's going on dramatically reduces the time that I need to then formulate the diagnostic plan. So knowledge is power. And does it have to be at the point of care? Well, it depends on what's going on, obviously. But if I'm seeing the patient now, if I know what they have, there's all the benefits that I've already talked about. Let me not waste time doing unnecessary tests, unnecessary procedures, providing unnecessary therapies. Let's focus in what I know you have. And so, you want diagnostics at or near the point of care. I don't mind if I have to wait. 15 minutes is ideal. If I have to wait 2 hours, I can still use that information, very well. If I've got to wait 3 days, I've lost a lot of the potential utility and wasted time and potentially not treated or mistreated or overtreated or overdiagnosed. And so point of care is literally where it's at.
Thank you. Next one is, are there any other viruses that should be tested for when a patient presents with flu-like symptoms?
So I really think it depends on the setting and the patient. Again, knowledge is power. And so the question is, how will a diagnosis impact my evaluation and treatment of the patient? So one thing is, does it impact how I treat? Influenza, we've got antivirals. So if I know I have a diagnosis of influenza, I have a specific therapy that I can give, depending on the patient, where they are in their illness, etc., that I can use to make the patient better. And so that's powerful. For the hospitalized patient, knowing that, again, the cause of their fever is a specific respiratory virus, it's RSV, that's powerful. Again, I don't have to worry that they have some other complication. It helps me isolate the patient effectively. That's powerful as well. And so in hospitalized patients, I'm more likely to want to know what they have specifically and have an expanded diagnosis. What do they have? In the outpatient setting, I don't need to know that every child who presents with a runny nose and a fever that they've got a rhinovirus. Really doesn't help me. Knowing they have influenza, I can do something specifically. Knowing that they have RSV, for example, it's a 6-month-old, that's going to heighten my concern about their clinical course, because I know how significant bronchiolitis can be. And so it may not impact my initial management of the patient, but may cause me to follow up closer with the patient. And so that can be very powerful as well. So again, bottom line, it depends on the setting, it depends on the patient, but knowledge is power.
Thank you. Next one is, why was last flu season so severe since even people who were vaccinated were getting the flu?
Well, it was so severe for a number of reasons, some of which I've already highlighted. It was an H3N2 predominant season, and those seasons tend to be more severe. As I also said, unfortunately, the vaccine was not as effective as we would have liked it to have been. Only 25% protective in general against the predominant strain. But another reason I think that contributed to it was the fact that fewer people were vaccinated. There was a recent report, and I forget the precise numbers, but among adults, it was something like 6% fewer adults were vaccinated last season compared to the previous season. And I don't understand that. Vaccination coverage among children was pretty much the same. And I would highlight that not only was coverage was lower, it's still low. Even the year before it was lower than we'd liked it to be. Realize every person that gets vaccinated against influenza not only reduces their own likelihood of getting sick, but reduces the likelihood of other people getting sick. And so, we want for ourselves and for others for as many people to get vaccinated as possible.
Thank you. Looks like we have time for one more question. What is the prediction for this coming flu season in terms of severity, and which strains will be circulating?
One of my favorite quotes is that making predictions is very difficult, especially when it's about the future. And so I hesitate to make predictions. And every once in a while we get totally surprised. So far, if you look at what's circulating in the United States, and again, there's only sporadic activity, it's predominantly influenza A viruses, and so far, what we know is they appear to be good matches with the strains in the vaccine. So that bodes well. Could change, but that's comforting, and the CDC continues to monitor that. We also know last year was a very severe H3N2 season, lots of illness. It tends to cycle a little bit. A lot of people got sick. It makes it less likely that, for example, H3N2 would be as severe this season. Another source of information comes to what happens in the southern hemisphere. So their winter is 6 months different from up in the north, what we have in the northern hemisphere, and so their influenza season ended August, September or so. In their influenza season, the pandemic H1N1 virus was the most common type. So if you were to make a prediction, you would think that it would probably be an H1N1 predominant season, that might be, and would tend to be less severe than last season. But again, I wouldn't put any money on it. And you should treat it as this could be another bad year. Make sure you get vaccinated, protect yourselves and your loved ones.
Thank you. Oh, I'm sorry, we have one more question. This question is, on the first slide, is this Captain Kirk or Captain Picard?
That is Jean-Luc Picard. That's Star Trek: The Next Generation. Love Kirk, but you can't find a better leader than Jean-Luc.
I would like to once again thank Dr. Lieberman for his presentation. I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. We would like to thank our sponsor, DiaSorin Molecular, for underwriting today's educational webcast. This webcast can be viewed on demand through May 2019. Labroots will alert you via email when it's available for replay, and we encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.